We should have this ironed out. Okay, so thank you all for joining us. My name is Justin Parkhurst. I'm currently the chair of the steering committee for the LSE Global Health Initiative. The Global Health Initiative is an interdepartmental research unit here at the LSE, which attempts to link together research and interests in global health across the school. But we're also very proud to and happy to host speakers and events and the like. And so I will be very quick with the introduction because we're running a bit over our start time, but it's a real pleasure to have Rob Yates join us, who is the director of the Global Health Program, executive director of Center for Universal Health at Chatham House, a political health economist specializing in universal health care coverage and progressive health financing. So I won't say much more than that in the interest of time, but thank you so much for joining us, Rob. You'll be speaking for around half an hour, 40 minutes. Yes, or so. Got some slides, so I'll share the slides on screen, and then we'll hopefully have plenty of time for questions as well. So I will start the slides, share the slides.
Great, thanks very much, Justin. And just trying to work out the best place to stand really in this sort of.
I think here by the microphone.
Here, yeah, it's like mission control here, isn't it? Really. So if I could have the the sort of the standard view there, that'd be great. Thanks very much. And it's just sort of click. Like that. The arrows, marvelous. Thanks. Great. Well, thank you very, very much indeed for having me back into your fantastic new facilities here. It's an absolute honour to be speaking to you today. So, as Justin was saying, my name is Rob Yates, and I'm the executive director of the Centre for Universal Health at Chatham House. And I want to talk to you today about universal health reforms, and particularly the politics of universal health reforms. And ask the question, will permacrisis create a new generation of universal health heroes? And for those of you who don't know what permacrisis is, so you might have seen it in the media recently, it's apparently the Collins Dictionary word of the year to describe this ghastly world in which we live at the moment, beset with multiple crises associated with food security and energy and conflict, and obviously the climate emergency. So we are living in a world of permacrisis, but I want to try and be upbeat and optimistic this evening and suggest that out of dreadful periods, some quite good things might happen, including potentially universal health reforms. But first of all, if I can sort of start with a definition. I don't know if it's possible to leave, if I just click this here, that should display. There you go, yeah, marvelous. And this is around universal health coverage. Now, I'm sure 90% of the audience know this already, so bear with me a second, but I think it's always important to sort of have a definition like this at the beginning, because people often associate universal health coverage with health insurance coverage. People sort of think coverage insurance and just assume that I'm going to be talking about insurance. But it's very important that we go back to basics a bit, really, and use this type of definition, that all people receive the quality health services they need without suffering financial hardship. So you can see there are these three aspects to this: the universality, everyone, the services allocated according to need, but then this very important issue about not suffering financial hardship. People aren't plunged into poverty while accessing health services. Right, didn't like that. No, it seems to have frozen on me there. Next, I'll try next. There you go. Right. So, yeah, no, it seems like it. But so before the pandemic, I think it was the case that universal health coverage was sort of driving the global health agenda. Even made it to the front page of The Economist. And in fact, The Economist have just come out with a new film, small film about universal health coverage this week. So it's a very, very important topic. And you sort of saw just before the pandemic in September 2019, a high-level meeting held at the United Nations with heads of state speaking about universal health coverage. And there's going to be another of these high-level meetings next September at the United Nations. There was a specific resolution at the UN, December the 12th, 2012. So we're coming up for the 10-year anniversary of that. All countries signing up to this. As I say, it's a designated UN day now. Next Monday, UHC Day, there can be lots of celebrations, lots of things happening online. Look out for that. It's a target in the SDGs in its own right. And many of the agencies, big agencies, WHO, the World Bank and the like, were really saying that the best way to achieve the health SDG, certainly in terms of the health sector's contribution towards SDG 3, is through universal health coverage. So very much sort of dominating the global agenda, and then along came the pandemic, which maybe I think skewed things very much, not surprisingly, towards infectious diseases and health security. But now many people sort of saying that the best way to avoid pandemics and sort of build a strong health system is basically still on universal health coverage, but doing a better job of including public health services within your UHC reforms. Right, now I just want to do a sort of little quiz time. We're coming up for Christmas, so I'm going to sort of ask a question around a couple of photos I'm putting up now. This is almost like an example of UHC style health reforms. This was a photograph I took in April 2010, Monday afternoon, 3 o'clock. In this health centre, there were 2 members of staff there off camera, but unless we're providing health services for chickens, you know, this facility is not providing any health services at this point. And, you know, in terms of it contributing universal health coverage, practically useless. I went back 4 days later, 3 days later, on Thursday, and it was packed with pregnant women and children getting health services. Now, the question for the audience, what happened between Monday and Thursday to have that impact? Payday. So people have got money in the pocket and therefore can go to the health centre. No, that's not right. Transport. There were buses put on potentially that could get people to. Yeah. No, it wasn't transport. You're saying some special services put on that day that would potentially benefit pregnant women and children. No, that wasn't it. Yeah.
Was it closed on Monday?
No, there were the health workers there, but the same health workers there on Thursday, but all of a sudden people there. Yeah.
Community outreach?
No, not community outreach. No.
User fees?
You've got it. Yeah. It was free. The services were free. On Monday you had to pay for them. On Thursday they were free. And it's interesting. I mean, I give this talk many times before. Justin's heard this at least a couple of times. It is interesting, particularly when I've given this talk at medical schools, you know, sort of people are straight into the supply side stuff. There were more doctors, there were more nurses, there were more medicines and that. But no, this was quite simply, it was a supply side thing. And in fact, I can show you the exact time things changed. 8 o'clock in the morning, this is the picture I took looking down the crowd trying to get into the children's hospital. It was only free services for pregnant women and children, and quite extraordinary scenes. They couldn't open the doors, and the doctors were having to go out into the crowd to sort of triage and find the sickest children and try and bring them into the hospital. It was astonishing, and I think I've got to and it was led by the president. The president, and this day, the April 27th. Independence Day. You know, this was all chosen to have this maximum impact. And I went round the peninsula that Freetown's on that day, and it was quite astonishing because wherever you turned up at a village, you didn't have to ask where the health centre was. It's where all the people were. You know, sort of people were celebrating, and very, very emotional scenes that day. But very significantly, it was led by the president. And I just want to sort of go back to, sort of why the politics of this and why this is important and why this really is as much a political agenda as it is a technical one. Because going back to that definition of UHC, it is all about equity and fairness. We are talking about, everyone getting services. No one should be left behind. Now, admittedly, in that case in Sierra Leone, the start was pregnant women and children, which in many respects is quite a sensible group to start with. But we're talking about services allocated according to need. And obviously pregnant women and young children are high need groups, requiring many services, many preventive services. If you're going to have this system whereby nobody suffers financial hardship, then you obviously need a system that is funded according to people's ability to pay. Richer people paying more into the system than poorer people. I mean, that was the whole point of that initiative before. And I've got even some other pictures of women in the clinic who only lived about 500 meters from that hospital, had never been before because they couldn't afford it. And they were poor, but now they could go. So what we're really talking about is a health system where healthy, wealthy people cross-subsidize the sick and the poor. And I'm sure you all here at the London School of Economics, you're all very familiar with this. But I do want to dwell a bit on the financing aspects, because whereas it's true that universal health coverage is all about broad health systems reforms, looking at your human resources and infrastructure and medicines and IT and all systems, the absolutely one you have to get right, which really, if you get that right, it provides the resources that you can reform all the other ones, is the health financing system. And this has been a really big battle over the years, often ideologically driven about how one should finance your health system. About 30 so years ago, the likes of the IMF and the World Bank and the British government, and the American government, were basically telling developing countries, put the burden onto households. You should charge user fees. I mean, the reason Sierra Leone was charging user fees in the first place, because the World Bank forced them to do it. And that was a terrible, terrible mistake. But what the world has learned around universal health coverage is, it's not surprising, a market-driven system where you buy and sell services like you would, say, restaurant meals or buying a drink in a pub or something like that, will never, ever achieve universal health coverage. And that's obviously because a number of these services are expensive, and poor people won't be able to afford them if they're just being sort of bought and sold. That you need, if you're going to have those subsidies happening at scale, the state must be involved to force healthy, wealthy people to subsidize the sick and the poor. You can't do it through charity and GoFundMe pages and stuff like that. It has to be all organized by the state, with the state being involved in how you raise the money in a fair and progressive way, so the rich pay more, how you pool the money, so you've got the resources available to cover the entire population. But then on the spending side, on the purchasing side, discussing, where are you going to allocate the resources? Are you going to open more health centres, targeting pregnant women and children? Are you going to provide kidney transplants? What can you afford for the money you've got available? So huge role to basically for the state to socialise the health financing system. Now, this doesn't mean necessarily that the state has to do everything and provide all the services. And there are many good examples of UHC system where the majority of the providers are actually private sector providers, but the state controls the financing. One thinks of Japan and Canada and France and countries like that. And even some aspects of the NHS, GPs are private practitioners, and you have hospice services, which are predominantly in the charitable sector. So, but the key to UHC is public financing. And I think we can finally say that with some confidence after these terrible battles over the last 30 or so years. And someone who said this very eloquently at the UN high-level meeting back in September 2019 was Gro Harlem Brundtland, the former Director General of WHO, former Prime Minister of Norway, and now one of the elders, this sort of group of former world leaders advising on things like this. And she said, if there's one lesson the world has learned, you can only reach UHC through public financing. And I think that's obviously a sort of crucial message that we need to be relaying. And I think this graph illustrates this very well. The data is a bit old, but I mean, if we've been updating this recently with 2019 data, it's basically the same picture. This sort of illustrates, I think, the transition to universal health coverage. Here you've got, yes, the predominantly wealthy countries in Asia with high spending as a share of GDP in public spending. This isn't total spending, this is public spending. And this has the result that in these countries, people get good access to very good quality health services, and they don't have to pay out of their own pocket. So not surprising, the out-of-pocket spending as a share of total health expenditure is really quite low. At the other end, you've got very low spenders in public health spending, but people still need health services in these countries and are having to shell out enormous sums out of their own pockets. But this is associated with poor access by poor people, people buying medicines over the counter, so poor quality health services, but also millions of people being plunged into poverty because they're having to spend so much money on health services. So the transition to UHC is replacing private voluntary financing with public financing. And you see some countries down here who are making pretty good progress for their income levels. And these are associated with what you regard as good UHC models. And what's fascinating about this is that you would think perhaps that, you know, the transition down that curve is that as countries get richer, they sort of maybe gently glide down that to like a slide or something. That doesn't happen. What tends to happen is countries make big jumps. They go from up there, and then what can appear quite suddenly, maybe in a couple of moves, make big, bold moves to socialize the health financing system. And what tends to happen, not surprisingly, if you are going to suddenly put in, you know, like 1% of GDP, which can, you know, do a lot, that type of decision is made by the head of state. It's the Minister of Health can't do that. You know, the Minister of Health would love to do that, but it's very rare that a Ministry of Finance is suddenly going to put that type of sum in, because of course 1% of GDP, you know, potentially is 5–10% of the budget. I mean, we are talking quantum leaps. And transitions to UHC tend to happen in big, bold, sudden moves. And what we're particularly interested in, the work we're doing at Chatham House, I'll explain in a moment, is how can we help in these countries catalyze these reforms? What does it take for them to suddenly to make this change? And someone who has really got it about, you know, the people to target in this is Dr. Tedros at WHO, himself a former politician. You know, he was foreign minister and health minister in Ethiopia. He, and particularly in the UHC work, is doing very keen to talk to heads of state, heads of government, hence this interest in things like the high-level meeting about the opportunities for countries to sort of make these transitions. Now, you might think, again, you know, 1% of GDP, 2% of GDP, that's a lot of money. What chance is that now? You know, we're talking, we were just talking about permacrisis, you know, with, you know, pressure on budgets and food crises and having to subsidize energy and all these problems that heads of state are facing at the moment. So you might think, well, you can forget that because there's no money around. What I want to sort of talk about the next sort of 15–20 minutes or so, if you look through history, funnily enough, now is exactly the type of time that these things tend to happen, because we have just been through, or still going through, you know, the biggest health shock in over a century, which I believe, and we're seeing already, could potentially catalyze a new generation of UHC reforms, because you can see right across the world that people have been looking to their governments to provide them with effective health services, vaccinate them, make sure they got services when they got sick, also provide financial protection. You know, that we've sort of seen it in attempts to protect sort of people's incomes, but really this sort of dual thing of helping people get services, particularly health services, and protecting household incomes has been almost universal approach that governments have been funding. And what we've seen is that people want universal entitlements. You know, you can't have this situation that you say you leave whole swathes of the population out, particularly things like vaccination programs, because, you know, that's dangerous for everyone. So everyone, even in the United States, very interestingly, you know, their approach to vaccinating the population, none of this, you need to show your insurance card or you know, it's related to your employment. Universal, tax financed, come and get the vaccines, please come and get the vaccines, because this is going to benefit all of us. And populations wanting results quickly, you know, big expectations that the head of state was going to step up. And I would say that this urgency to help people is even greater now that we are facing these other shocks, energy shocks and fuel shocks. And there is this big pressure on exchequers to help, you know, the cost of living crisis. Now, you might say the obvious thing to do is like put money in people's pockets or subsidize their fuel. but in many respects, that's not the best way. You know, we want to sort of get away from subsidizing fossil fuels. So this might be a better option, or as a package, to provide people with free health services. And we are seeing the COVID crisis having a big impact on politics. Because of all the crises at the moment, you know, there's a natural inclination for populations to feel fed up and angry with the politicians who have been in power. And we've seen, you know, some stepping up and taking it seriously and getting re-elected, and others, you know, Donald Trump, you know, sort of, voted out of power in no small part due to his inept COVID response. And really, you know, let's face it, that has been the demise of Boris Johnson as well, you know, very much associated with his personal behavior. But you know, this is a sort of rather cutting cartoon here, you know, but this idea that they were partying while the population was dying doesn't play very well with the electorate. And we've seen the consequences of that. And of course, the latest casualty of that is Bolsonaro in Brazil, suffering a similar fate as well. So politicians are on watch at the moment, you know, that they are feeling particularly vulnerable. And I now just want to sort of mention the historical precedents of UHC reforms coming out of crisis. We're not making this up. That, you know, there are so many great examples of very successful UHC reforms coming out of crisis. One of the most famous is here in the UK. That's, you know, at the end of the Second World War, the UK was bankrupt, was a post-conflict state. It was dependent on US aid. And the incoming Labour government, you know, put a very different package in front of the British population. I think Churchill just assumed he was going to win the election because he'd won the war. But, you know, Labour, it was all about building a welfare state out of the rubble of the war. And this is Nye Bevan, the architect of the NHS, literally on the day of its launch, the 5th of July, 1948. And we all celebrate it as a great institution, which gets battered around and kicked around as a political football. But still, when we had the Olympic Games in London in 2012, we celebrated it as one of our sort of great achievements. And survey after survey shows it is the most popular institution in the United Kingdom. But we weren't alone. I mean, Japan did the same thing at the end of the Second World War. France did the same thing as well. So out of conflicts can come universal health reforms. A different type of crisis was the Asian financial crisis of the late 1990s. And the Thai economy in particular crashed, and there was a lot of anger at what had happened there, which allowed Thaksin Shinawatra to come in as Prime Minister. And one of his great planks of his election campaign was to introduce a publicly financed universal health system. And proved very popular, won him the election, and Thailand has got one of the best UHC systems, certainly for its income level in the world, and we all celebrate it as a great success. And what was interesting was at the time, the World Bank said to Thaksin and Viroj and Suik, all these people who sort of designed the scheme, you can't afford to do this. There isn't money in the economy. You cannot afford to do it. You mustn't do it. But the Thais ignored them and did do it and tax finance it. And you see this step up in the public spending. And but it was interesting in 2013, the president of the World Bank, when speaking at the World Health Assembly, congratulated Thailand for ignoring World Bank advice. Very public. I mean, it was Jim Kim, to his credit, who said that. And I think that being very relevant for today, you know, that, you know, don't let it be said that you can't do this because Thailand shows that you can. Other more recent examples, this is the then governor of Jakarta in Indonesia, who a month after coming to power in 2012 introduced a universal free publicly financed health system in the capital, and just came bolt out of the blue. I was lucky to be working for WHO in Indonesia at the time, and it was like, wow, this is terrific. He did a Thaksin and won, and then campaigned in the presidential election to bring this to the entire population. And we were fortunate to be helping advise him at this stage. This would be a smart thing to do. But it was very interesting that he didn't know that Thaksin had done this in Thailand. He'd never heard of universal health coverage. And when I asked him, why did you do this universal thing in Jakarta? he just said, because the people asked me to do it. You know, he was a smart politician who recognized he needed to do something quick and dramatic, and he introduced these reforms. Unfortunately, he hasn't done it at scale now that he's president. You've seen it go up a bit, but he's still means testing to get these cards for, you know, publicly financed. You have to sort of show that you're below the poverty line. So they got to about 80% coverage, but you feel he just needs that final push. I mean, he's still got a couple of years left, so perhaps he will. But there have been attempts to sort of try and encourage him to take that final push. This is the then chair of the elders, Kofi Annan, speaking to Jokowi about, you've done amazing things here, but you could really finish the job off and go down as Indonesia's UHC hero. And any of you with connections with President Jokowi, that message is still very, very valid. But we're seeing right across the world this happening now, and even in countries, you know, that historically where access to healthcare hasn't been a big political issue. For example, India, the world's biggest democracy, where 15, 20 years ago, this wasn't really registering as a big electoral issue. But then the Prime Minister Modi, when he came into power about 2014, launched Modi Care reforms. Now you can sort of see, you know, Obamacare, Modi Care, you know, that politicians like putting their names to this type of stuff. But the problem with Modi Care, again, it's means tested. It's only for people below the poverty line get the free cards. And also, it's very geared towards inpatient hospital care. Doesn't cover you for essential medicines, which is the main source of out-of-pocket spending. So personally, I don't think the Modi Care reforms are proving very effective. But again, you're seeing now different states in India doing different things. This is the Delhi state government, and this is the chief minister here, again with the elders, where Delhi's doing something very different. They've launched universal free primary healthcare through these little clinics called Mahala clinics, which have proved massively popular, with people switching from the private sector back into the public sector. It was said that this wouldn't happen in India. People had just given up on the public sector. Not true. People are coming back and using these in their millions now. And very interesting that the AAP government that runs Delhi is now promoting this model in other Indian states and won the Punjab elections earlier this year, and are bringing this model across India. And it's very, very hot politically, because not surprisingly, the Prime Minister is not very keen on this. Just a couple more examples. That China, after the SARS epidemic. Now, China was interesting because for years it was very much associated with having a publicly financed health system, barefoot doctors, big emphasis on primary health care. But as the economy grew and developed, there was quite a lot of neglect to public financing of the health sector, and the government sort of allowed private financing to take over. So you can see on this graph through the 90s, the share of patient financing rocketed. But it was the SARS epidemic where the government suddenly realized that hundreds of millions of people weren't accessing health services because of this privately financed system. And it resulted in big, big political pressure building, with hospitals being burnt down and doctors being killed. And the Communist Party thought, crikey, we've got a problem here. What's going on? And around this time, they decided to, in effect, re-socialize the health financing system. And this graph from the Economist is slightly misleading because it sort of gives the impression that these things are different, but these combined are public financing. And you can see this public financing replacing patient financing. And again, you just look at the stories of the last couple of weeks, because it's pressures building again for access to services in China. Those services being basically mRNA vaccines. You know, the population is still, a lot of the population is still under lockdown because, you know, they're not getting access to vaccines. And there's a huge kerfuffle debate at the moment between the American manufacturers of mRNA vaccines and the Chinese government about, you know, whether they're going to be licensed to be provided in China. So again, political pressure building in China over access to health services. But I think it's interesting that you know, looking at lessons from the pandemic, where, you know, we need to be honest that, you know, the West didn't step up and help developing countries as much as it should do. You know, that they didn't share vaccines, they didn't fund Act A properly, they didn't facilitate tech transfers. And I think a number of leaders now are sort of saying, we just can't depend on the West anymore. We are going to have to finance our own health services, going to make our own vaccines. And this was President Kagame towards the beginning of the pandemic, very much calling on African countries to increase domestic financing for their health systems. And I think looking at what the UK's done in slashing aid financing, including health financing, the trend is downwards in health aid financing. So I think so many countries now are realizing that the West isn't going to sort of support them adequately, and they are going to have to domestically finance their services more. And maybe this being an opportunity to really kick on and do that, because there are leaders who have said they're going to use the crisis to catalyse their domestic health reforms. South Africa, which given its income level should have done this 25 years ago. President Mandela made a start. He introduced free healthcare for pregnant women and children, but successive presidents didn't really take it very seriously. Although President Ramaphosa has shown signs that he wants to, and there's a national health insurance bill going through Parliament at the moment that would in effect create a South African NHS. Not surprisingly, there's lots of pushback from the insurance companies and the private hospitals, and the titanic political battle being fought. I'm not sure if anyone is from South Africa here. It's a big issue, this. But maybe he's going to go for it because he's under a lot of pressure himself at the moment. The various scandals brewing. So he may be up for this. Nigeria, where anyone from Nigeria, right? Well, this was taken at Chatham House, just I think when President Buhari was running for president, and there was this hope and expectation he was going to really kickstart UHC reforms, and he hasn't done really, has he? There have been some small moves around the NHI, but if you look at the financing, it's been a bit modest. Yeah.
We have data challenges on how to pull the fund at national level. Majority of people are employed through the informal sector.
Yeah.
So they need to actually first, what they are currently doing now is to implement what they call the national insurance number. And everybody can get that. That is linked with your bank account. So they were hoping that they're going to use that angle to pull fund at the national level for both the formal and the informal sector.
Yeah. So there's movement there. There is movement there, and in fact, you have presidential elections coming up, and you'll be perhaps aware that one of the presidential candidates in London at the moment, and in fact was in Chatham House on Tuesday. So maybe it will really kick on now. And Nigeria, if you look at GDP per capita, Nigeria's GDP now is similar to what Thailand's was in 2002 when it launched UHC reform. So it could be done. You're just looking for that politician to fly with it, and then, of course, the big one, the United States, the country that famously went off in its own way and didn't really create a socialized health, well, not a truly universal one after the Second World War. This was actually still taken from a little video, and you can find this online, actually. You can hear Hillary Clinton say to Biden in the run-up to the elections, don't waste this crisis. Don't waste the coronavirus crisis. Now is the time to launch universal health reform. She tried to, but wasn't successful. But, this big movement to sort of try and get the US to finally do it. Unfortunately, Biden, quite conservative, and he's been trying to, really preserve the Obamacare reforms, but needs to go further. I mean, cut to the chase, US needs a single payer health system. And this was a tweet, actually, that Biden put out only a couple of days after being elected, saying, come January, you're going to work with Congress to ramp up healthcare protections, get America to universal coverage. So he says he's going to do it, but he hasn't really done so yet. But there are political leaders in the US who are really keen on this. This is the governor of California, Gavin Newsom, who sort of swept to power with the backing of a lot of the health workers, a huge advocate for a single payer system. And he's very much sort of the darling of the progressive left at the moment in the US, and potentially could be a presidential candidate next time round. So maybe, let's see, you know, what's going to happen in the US. So I just want to mention very briefly now, you know, I've been sort of talking about all these opportunities in countries thinking about these things. Some work that we're doing at Chatham House is to set up a commission for universal health to try and help catalyse these, try and move these things on, mixing up countries that have launched UHC reforms, even out of crises in recent times. So we have the architect of the Thai health reforms, the Mexican health reforms, the Cypriot health reforms, as commissioners, trying to help advise some of these countries like South Africa and Bangladesh and India and Pakistan, that we feel are at an income level and with politicians in power or vying for power who might be interested in doing this. And our co-chairs, Helen Clark, the former Prime Minister of New Zealand, and Jakaya Kikwete, the former President of Tanzania. This was at our launch, and one of our commissioners there is Olana Suprun, who is the former Ukrainian Minister of Health, who pushed through very bold UHC reforms after the first Russian invasion in 2014. And she speaks passionately about what she did, how she was able to do it, really using the crisis to push through UHC reforms. And I should say Arush in the audience here is one of our commissioners as well. And we're extremely grateful for his advice and expertise on the commission. Last slide, you know, and really to sort of try and sum up what we're thinking, you know, with this approach and what we're trying to do, is that COVID-19 is obviously the biggest health crisis in over a century. And leaders are now facing multiple crises, you know, and are really panicking about, are they going to stay in power? What are they going to do? That people are putting huge pressure on their political leaders to help them through this crisis in multiple different ways. And some leaders are coming up with sensible policies and some, you know, plainly ridiculous policies. And it's sort of really open game at the moment as to which way they're going to go. Urgent action is needed, particularly around access to health services and providing financial protection. So in many respects, even though it feels pretty awful at the moment in permacrisis, now really is the time to be getting out there promoting UHC reforms to political leaders. And when we launched the commission and Dr. Tedros was over for the CEPI replenishment, and we told him about what we were doing, he said, "Oh yes, this is great." He said, "We've got to strike while the iron is hot." You know, it's health is high on the agenda at the moment. If we retreat and we say, "Oh no, there's not enough money, we'll just wait our turn, we've had it." So I think really, you know, the message is now the time we should get out there and approach political leaders. And what we're very keen as a commission in Chatham House is for ideas of people we should be talking to, you know, who are the types of politicians who might run with this. And who knows, someone in this room might find themselves running for president one day themselves, you know, so if they do, just give us a call. Thank you very much. Thank you.
Thank you so much, Rob. That was fantastic. And I think it's really great to point out this window of opportunity that many are pushing for change. And so we've got plenty of time for questions. And I will also open the chat here and to see if we've got any questions online. Let's just have a quick look at the chat. We often default to the QA. So yeah, please. So here's one comment in the chat. "It's difficult to compare across countries. We need to unpack UHC. What services, the benefit package? Are they getting for free? When do they not incur out-of-pocket payments? Must vary from one country to the next." I don't know if you want to.
No, absolutely, and of course, you know, every country is different, and their disease burden's different, and you know, some have got, you know, infectious disease and tropical diseases, and they obviously need to sort of tackle those. Others don't have that, and depends on your age structure. And of course, it also depends on your economy, you know, sort of how you can raise funds. So every country has got its own history and institutions as well. But I think these basic principles about the importance of moving very quickly to a universal entitlement, so everyone feels part of it, and a benefit package that is cost effective and is available for everyone, and reducing financial barriers at the point of access, free or massively subsidized. These are all the features of the successful reforms. And I think countries that try to segment the population and fragment and charge user fees for some and not others, that doesn't tend to work.
Right, so please, if you're online, if you have other questions, put them in the chat and we'll keep looking for them. So we can open it up to those in the audience. So hands up if you'd like to ask a question. I'll give a minute if anyone else would like to. Okay, so we've got 1, 2, 3, 4, 5. So can I start here with 1 and then 2, 3, 4, and 5, if that's okay. And hopefully, let's take 2 to start with, but remember that order. So please.
Yes.
Yeah, sorry.
Yeah.
Thank you so much for such an interesting discussion and presentation. The question is, right now, the pandemic treaty is being, there are negotiations going right now on the WHO. So what would you consider is the role of UHC in the negotiations that are ongoing right now?
Do you want to take one question at a time or take 2?
But may take a couple. I find beyond 2, I'd forget.
Okay, so 2. The second one was here.
Thanks, Robert. I'm Dr. Ramon. My specialism is intellectual property law. I'm very interested in many of the things you raised.
Yeah.
I just want to bring up the issue of the WHO mRNA technology transfer hub, which fits very well, I think, with the reputation. It's a South-South initiative, which is the way forward, as you say, given the failure of the West to share sufficiently the technology to make vaccines. It's obviously it's led in South Africa, but it's going to 15 different countries in the global South. There is one major Western country institution that is part of it, the National Institutes of Health, the US Barney Graham, is heavily involved in sharing technology. So there's a sign for hope there, that's for sure. And one of the things I liked about your presentation was the optimism. We're in short supply at the moment. The skeptic would say that, particularly on certain issues to do with universal healthcare, or whether it be intellectual property rights, the lobbying power of the pharmaceutical industry is so overwhelming. I mean, the last comments that they submitted to the US Federal Trade Commission on intellectual property trade was that, in their view, all forms of socialized healthcare, whether it be in the UK or South Korea, are harmful to innovation incentives. That's the exact words they use. So this is the enemy you face if you're trying to make reforms, particularly in the US, is that. So I just wondered if you have any thoughts about combating.
Okay, and I think a request to repeat the question. So if you want to just repeat what you're speaking to.
Sure.
As you answer it, so that those online can
the first question about the pandemic treaty and the implications that has for UHC or UHC for the pandemic treaty. And yes, absolutely, definitely. And I think it's interesting because I think, and unfortunate that I think we have seen this fragmentation of people treating health security and UHC differently and seeing them as different things. And this does my head in, to be honest, because it's so daft of us in global health to be doing this, because they're the same thing. They are basically the same thing. That it is all about everyone being protected and getting services, and it's sort of, I think, sort of quite arbitrary, this sort of distinction between health security and universal health coverage. Tedros talks about 2 sides of the same coin, UHC and health security being 2 sides of the same coin. I do think it's fair criticism that UHC, and this is why I go back to definitions, has been associated too much with health insurance and hospitals and curative services, and that is a problem, because I think it has meant that the public health services have been neglected and haven't been covered properly. And I think it's a real challenge for the UHC communities, and something that hopefully is going to be discussed at high-level meetings coming up later this year. But we've got separate high-level meetings on pandemic preparedness and UHC, and even on tuberculosis as well. So, we're not doing a brilliant job at integrating these, but I think it's very, very important that we do. And that in the treaty, that these principles are nailed down, that we are talking about access to vaccines and technologies being truly universal and allocated according to need. And it was a monumental failure. You know, that everyone was saying it. Well, the UN Secretary General was, Gordon Brown called it the policy failing of our generation. You know, the fact that, you know, people like myself and my kids were getting vaccines when, you know, health workers in Africa, you know, risking their lives on a daily basis were completely uncovered. So that has been a big failing. So you feel that including in the treaty things like new rules about allocating technologies equitably around the world really are based on the principles of universal health coverage. So I very much see these things being sort of locked together and hope that we can maintain that. And coming on to the question I was asked about intellectual property rights and the power of the pharma lobby to work against that. Yes, it is monumental, and you know, sort of, and we saw some progress being made. You know, I think the surprise that the Biden administration supported the TRIPS wave of vaccines. We, you know, Chatham House have been quite active with the People's Vaccine Alliance, you know, sort of trying to move things on there. But you're absolutely right. I mean, it is quite staggering. And of course, it's that lobby that is the main blocker for any moves towards universal health system in the United States. But you know, these things are overtly political, and you know, I do think the performance of our governments through the pandemic were terrible, particularly the UK. I mean, you know, it was the UK that hosted the G7 in 2020 when the IPPR had made absolute crystal clear asks about sharing stock, you know, releasing the stockpiles, funding Act A properly, and tech transfers. And the Johnson government did nothing, absolutely nothing. It was jaw-dropping. And really the way you tackle that is politically, and, you know, sort of vote out governments who behave like that. And, you know, I think to some extent we were unlucky maybe with the cohort of leaders that we had, Trump, Bolsonaro, Putin. I mean, just look at the group that we had when we were hit with this. Different to the reaction to the financial crisis in 2008, Obama, Brown, and people who saved the world economy. So one would like to think that perhaps the world has wised up and we're seeing the demise of a lot of this lot now, and that things might be different next time around.
Nice optimistic turn. I mean, in the interest of time, I might have to ask people to try and keep their questions and
my answers
a little bit shorter. We've got a couple more coming in online. I'll take the first one and then I'll come back to the room because I think it follows on a bit. It was this one here. How can we recognize there'll be demands for UHC? There's also strong voices against UHC. So, I mean, obviously the pharmaceutical industry, which we've just heard about. But also then asking what roles international organizations can play. So if the IMF failed, what about WHO, OECD?
Well, the good thing now is that I think that the international organizations are very much behind UHC and publicly financed UHC at that. I'd say 30 years ago, the IFIs were opponents, and you know, that it's to their shame that, and I think it's slowed down progress, you know, in many countries. But you know, recently, for example, you've had the IMF calling for the Chinese government to increase public spending on its health system because so many Chinese people were saving money to pay for health services, and this, you know, unbalancing the world economy. So I think that the global institutions now, the UN, virtually all the bilateral donors, you know, we're all agreed that UHC is A, a good thing, and B, public finance a good thing. But of course, there are political interest groups who don't want that. And we hear this in the UK, that the Telegraph and the Mail running editorials, we can no longer afford the NHS, we need private finance. Absolute nonsense. You know, I mean, it's more expensive. But to those interest groups, you know, there's big money in this. And so we always have to be vigilant. And sometimes people say we should try and keep politics out of the NHS, and complete opposite. We need the politics to be able to sustain it and maintain it.
Great. Okay, so we'll come back to two more from the room. Which was number 3? Was it 3 here and then 4? Is that right? Okay, so we take those 2. Please.
This might be a tough question, but as the proportion of GDP for health expenditure continues to kind of grow at a very steep rate in North America and Europe, does the threshold for emerging economies of the proportion of GDP that they need to commit to also proportionally increase? And does that seem that it is a tipping point where it's unattainable for those emerging economies.
That's interesting.
It now represents 10% or 15%.
That's very interesting.
So let me just, so repeating for the people online, a question about if we're seeing some countries, high income in particular, spending even more, higher and higher percentages of GDP on healthcare, is there a risk that the tipping point to reach UHC in emerging economies might be too high a percentage at some point to achieve that? Should we take one more question?
Yes, please. Yeah.
It's more about how can more middle-income countries implement this effectively. Countries like Pakistan, for example, have like increasing population, corruption, poor infrastructure. There's that significant barriers to implementation of UHC. So how can we facilitate it in implementing these? And will it actually be feasible and successful if implemented, given that it's hard as it is at the moment, and UHC will replace significantly.
Sure. Yeah.
So,
And if I can bring them both together,
Yeah.
and, answer that question as well about the low middle income countries and how difficult it is for countries like Pakistan to start off on this. I think what you see is that there have been many low middle income countries recently that have stepped up, and as an order of magnitude, you need about 1% of GDP roughly to really kickstart these processes, which is perfectly feasible. And I would say in any country it's feasible. And what you see is smart leaders using this as a way to get people to pay their taxes. It is true in South Asia, tax takes are very low in India, Pakistan, and Bangladesh. But that was the history in Latin America as well back in the day. And it's the classic social contract that if people get services, they get something back from the state, they're more likely to pay their taxes. So, and you do have to tackle the corruption. You do have to, make sure there's access to medicines. But I suppose the examples that we've been sort of showing here is that all types of countries have been able to do that. Democracies have done this, and more autocratic regimes have been able to do this. And there are some general guidelines about investing in access to medicines and paying frontline health workers and not blowing it all on tertiary hospitals. There's a sort of certain playbook, that unless countries are learning lessons from each other. And I would say that, it is still the case that so many of these countries that are flatlining at about a 1% GDP health spend, were they to go to 2, could see a huge difference. Now, once you get to 2, you don't stuck there, you keep increasing. And I think one thing that we need to be more honest about as a society, that as populations age and dependencies increase, and it's a big issue around social care for elderly populations, countries are going to have to spend more on their health and social care systems. It's a mark of a civilized society, so we shouldn't keep beating ourselves up like, oh my goodness, we're spending 10% of GDP now, we're going to have to spend 12% and 15%, and we can't afford this. We can afford it if that's what society chooses to do. I think we need that much more honest conversation that this is a good thing. But it's difficult to sell that we should be increasing taxes to care for our elderly relatives. But I am very grateful that that's available for my 90-year-old parents. And that will be where Pakistan and other countries will go in the future.
Okay, I'm just going to read one more from online, and then we'll come back to the room for one or two more. Gosh, a bunch of hands gone up. So I'll come to the room. There were a couple hands here as well. So this one online is saying effectively that if some have estimated that health systems are only delivering around 10 to 20% of health gains. I mean, I think that's depending on what study, but the question is then, should UHC come with a package of social services targeting more of the broader social determinants of health for the underprivileged in particular?
Absolutely, absolutely. And I should say that our work at Chatham House, we have 3 programs, one on universal health coverage, on health security, but also the social determinants of health. And it is absolutely true that so many health gains are delivered through better housing and clean air and better nutrition. So we mustn't kid ourselves that this is all about investing in your health system. But sometimes I think that's sort of overplayed a bit. You sort of hear some people say, oh, we don't need health services, you know, because all the gains are out there. But really, you know, we're not going to sort of bulldoze all the hospitals and sort of fire all the doctors, are we? And you know, if anyone were to suddenly get taken very ill here, we'd all be very grateful for our health system. So I think it's a balance, but it's very, very important that we in the health sector do team up with our colleagues in education and agriculture and make sure that the benefits of those sectors are shared equitably and fairly. And particularly, I think looking at SDG 10, which is the one I think about inequality, that we all take that one a lot more seriously.
Okay, there's one other comment there. It's very similar about UHC focusing too much on curative versus prevention and the need for an intersectional SDH approach. I don't know if there's anything else to add.
No, but I very much agree. This has been, I think, a failing, and unfortunately, I think it's a lot of it is the language, and we've got ourselves to blame for this. You know, that universal coverage, people associate it with insurance. Another term that I think has skewed policy is catastrophic health expenditure, because people associate that with heart attacks and cancer and operations and being in hospital for months on end. Yes, that can be very catastrophic. But the vast majority of health expenditure that's impoverishing people in developing countries, people buying medicines. And that is the big driver of impoverishment. So again, it's unfortunate that I think sometimes some of the terminology we use, people jump to conclusions about we need to be protecting people from the cost of hospital care.
Great. Okay. I saw some hands down here for the next question, and then hands up if you still want to ask, because I think we're going to only have one round. Gosh. 1, 2, 3, 4, 5, 6, 7 or 8. We'll see what we can do, but let's start here and take 2. So we'll start 1, and then was your hand up as well? So okay, so those 2, and then we'll see how quickly we can move on. So again, please keep your question brief if you can. Yeah, thank you.
Yeah. Sometimes, even if you have a lot of money in the system, you know, you have worked in Africa for a long time, so do I, so did I. So sometimes it's not exactly about the money, though. It's about the lack of HRH, human resource.
Yes.
Yeah, so that means you know, a lot of aid money that has been given is unspent.
Yes.
Yeah, at the end of the year, at the end of the project or whatever it is, 70% of the money. 2-3 projects I worked, they just the lack of capacity. They just don't have enough trained people. So I think the crisis that we are talking about is not only about the financial crisis, but I think it is an HRH crisis.
Yeah.
It's a crisis of people, right kind of people, not present in right kind of cases. I think we need to focus more on, and as you know, I mean, you are an economist. You know, health. Basically, the health industry is a labor-intensive industry. You know, 70 to 90% of the total budget goes on salaries, on people, and those who are providing the services. So only 10% is left. Actually, in many countries we have seen between 10 to 20% has left for other things. So I think what you are saying is absolutely 100%. I agree. But I do think that we need to focus more on capacities, as well as human resource for health.
Thank you. So so a question for those online, a question about human resources for health and the need to focus on that in particular. And yes, one.
It's very similar about the donor dependence from Somalia. So how donors are helping, because they fund many projects that are fragmented and they're leading to more dependency that the government are letting that finance to come, and they're doing another thing. So how the donors can help the countries to achieve UHC or prepare them to do that.
Yeah. So donor financing, fragmentation from donors.
Exactly. I think you both raise very, very important points. And I think this is around the relative efficiency of domestic spending and aid spending. And, you know, I spent a big chunk of my career, as you're saying, in sub-Saharan Africa, particularly in Uganda. I was in the Ministry of Health for 6 years. And I very much saw that what you were describing there, lots of aid financing being spent on workshops and trainings and sort of more sort of things of a capital nature, and not paying for frontline health workers. And you know, you might think that's necessarily the case, because, you know, sort of donors like to have projects that start 1 year and finish 3 years later. And it's a long-term commitment to pay salaries of health workers, and which is something that is very much underfunded. And I very much feel that domestic spending is so much more efficient than aid spending, because it's much more likely, when it's governed properly, to be spent on frontline health workers and you know, sort of building health centres and the real nuts and bolts of a health system. So I think we have seen in some situations a degree of donor dependency, and governments that should be spending more money on their health services just dependent on aid spending that's not really spent very efficiently and would be better spent on human resources. So challenging as this might be, this could be an opportunity for a number of countries to step up and fund their own health systems properly, specifically going for human resources, access to medicines, and spending less on workshops in hotels.
I mean, just to come in a little bit, maybe overstepping the chair role, but I mean, I think this has been a discussion and debate for a very, very long time in terms of, you know, donor finance towards recurrent costs, and they include salaries for that. But obviously, if you do allocate budget to staff, what you end up doing is you end up providing services which people then expect, and then they demand it in return. You also then have a cadre of educated workers, healthcare workers, who will do things like go on strike and demand, as we're seeing in the UK, you know, better pay and salary, and demand of the government. So you have to make that first step in order to get on that path at times. But it has been, that question has come up so much.
And the classic thing about community health workers, you know, which is a great idea, really fantastic idea, and lots of donors have run community health worker schemes, but typically haven't paid the community health workers properly for fear of the ongoing liability. And then these projects have collapsed the moment the donor funding is finished. The big challenge is to get those community health workers on the government payroll, and that happens very infrequently, and it's desperately needed.
Let's try and get a few more questions in. So hands up again. Hopefully, if you had them before, we can keep getting more hands. But okay, so we'll go to these two here. If that's okay. So yeah, please. No, it was your hand up as well. There's two. I saw two hands. Go ahead, please.
No, thank you. I think partly the question's been answered about HRH, but I suppose one of the things I'm interested in is whether you can use the Department for Education leverage a bit more in place, because to your point, actually a lot of the education health work doesn't happen in the Ministry of Health, and the Ministry of Education. And from experience, the cost of education to become a health worker, member of staff, is often prohibitive.
Yes.
So actually we're kind of stuck in this kind of weird vortex where we go round and round in circles. So I suppose my question is about the commission conversation. It's like, I'm assuming it's a multi-sectoral, it's not health. So if you, I don't know if you just speak about the makeup of the commission and why that's going to be.
Sure. Yeah, absolutely. Yeah. A multi-sectoral approach. Yeah.
If you get.
My question is just very simple enough. Based on your own opinion, do you have any technical solutions for like, do you think this model is better, or do you think the other model is better? Because we have been advocating for you this year. Is there, what do you actually think?
Sure. No, so happy to address both those. One about the public financing is a social health insurance model better than tax finance model. But I'll firstly deal with the first. It's Emily thinks. Yes, I think it is very important that one engages all sectors, and you know, this is a classic problem that ministries of health who try and do it on their own often run up against, you know, ministries of education who won't participate, or ministries of public service, certainly ministries of finance, which is the idea of the commission is to go up a level, to really engage the head of state, to make it a flagship policy, to make sure that all the government ministries are aligned with this. And a classic thing, and it comes back to the HR thing, is a ministry of public service who will say, oh, we're not going to increase the health workers' salaries, out of kilter with the rest of the public sector. And so you're not going to get pay increases for doctors and nurses until it happens across government. But that doesn't make sense because there's an international market for health workers, whereas there isn't so much for agriculture extension workers and even teachers domestically. So we need to have that latitude, but that's why you need the head of state to say, this is my flagship policy. I want education to cooperate. I want local government to cooperate, and bang heads together, you know, if that doesn't happen. And the question you ask about sort of financing, I think a lot is made of the differences between the British system and the German system, and it's almost like seen as a football thing. We're way better than you, and oh, good grief. That I think that's a bit of a sterile debate, really, because our systems are hybrids. You know, we actually use national health insurance contributions in the UK. The Germans use huge amounts of tax financing, as the French do as well. So we mix up our public financing mechanisms. And I think it's much, much better, and I try to in these talks now, just talk about public financing, progressive public financing. And if you raise it through employment taxes earmarked for health, which is social health insurance, that's fine, you can do that. You don't have to. I think the important thing, though, is that you don't try and assume that you can get money off the informal sector through health insurance contributions. At the end of the day, you do need to use tax financing to cover people in the informal sector. And this is becoming a bit of a golden rule. Poor people don't voluntarily take out health insurance.
Just quickly looking on the chat from online, you mentioned a global market for health workers. Someone has asked about the brain drain issue. So rich countries during COVID drain more health professionals. What can we do about that in light of UHC? And then there's a second short comment asking about your view on the role of technology in delivering UHC. So if you want to, if you can address those quite briefly, I think we need to start getting quicker. But then there's some hands still in the room.
Brain drain. This is this market for international health workers, and I think is a mixture of setting tighter rules that, you know, we don't poach so many health workers in countries like the UK, but as well that, you know, countries paying their health workers more, you know, they'd be more inclined to stay and work in their own health systems if they were paid better. So, you know, this is for countries like Nigeria, you know, they've got to pay doctors more, you know, and you know, that is the responsibility of the government. Technology. So the answer about technology, yes, technology, very, very important, particularly in improving efficiency and better value for money. And therefore, you know, to come back to the question about thresholds and what can you do at lower income levels, in many respects, you know, there will be opportunities for countries to do things a lot faster and more efficiently using technologies, say with community health workers. So technology can, again, play a very important role in making sure that the public financing goes a lot further than it would have done before.
Great, thank you. Okay, so I've got two questions in the middle here, and then we'll move to this side of the room after those two.
Thanks so much. So I kind of want to bring the conversation back a little bit from a crisis context, and really ask, you know, whether in especially today's context, permacrises might actually catalyze the right kind of health reforms that we actually need to see, particularly those that are rooted in the principle of equity and health equity. At the end of the day, you know, all the UN resolutions, UNGA 2012, the high-level meeting, all that stuff say that things need to be context-specific, which is fair. But if these things are so politically sensitive and you're having rising threats of infectious diseases like COVID-19, what we always tend to see is governments then first focus on making infectious disease control accessible, but they don't have money left over to support other kinds of interventions that support more vulnerable populations or more expensive kind of things. And so is that really going to catalyze the kind of health reforms that are truly universal? And secondly, are places like the UN actually the right place to be talking about this if the UN it's not even like health security where there's a cooperation aspect of this, because ultimately these are domestic reforms that are context specific. So is the UN really a place that we can see progress?
Very good questions. Thanks very much, Arush. You know, so, you know, is this best dealt with globally or domestically? I think was your second question, which is a question very sort of dear to my heart. And sorry, what was the first bit?
The first question was about, it's this permacrisis, I guess, is it providing the opportunity for universal reforms?
Yeah. Sure, I'll come up to
should we take that?
Yes,
the other
please.
question as well?
Yeah, I also wanted to ask about the permacrisis concept, just to be a little cynical about it. Like, I agree that the premise that it's a great opportunity to introduce reforms that encourage universal health coverage. My question more relates to the fact that since there are these ongoing, like multiple crises that you have to address as a head of state, you're saying that you require basically the top of the government to come and be like, this is what we're doing, and you guys all have to get on board. Since you are the head of state and you have all these conflicting priorities, how do we as a population or people that care about this issue kind of like actually make sure that it's actually at the top of the agenda as opposed to the war in Ukraine or food security or climate?
Yeah. And thanks very much. And to answer that sort of permacrisis, and are you going to get the health reforms that you want? This is very much the role of civil society and political movements to make sure that that happens. You know, you're seeing tremendous volatility at the moment, you know, in politics. You know, some governments are being voted in are right-wing nationalist governments, and you know, that's not good. You know, think of countries like Hungary. But say in Latin America, you've got Colombia, Chile, and Brazil now have voted out right-wing governments, and more progressive leaders have come in. Yes, you're right, with this great sort of shopping list of things. So it's very, very important that health activists and trade unions and the media telegraph to their leaders that, you know, they have these high expectations, they'll sort out the health system. I mean, look at the UK, you know, the battles being fought out in politics at the moment, and so much, we're heading into nurses strikes and ambulance strikes. There is going to be a titanic battle about this, and the government's going to try and pin it on the unions, and it's how is the country going to vote at the next election? It's hugely political, and the work we're doing in the commission is to recognize this, not pretend it's not political. It is political, you know, and I think for far too long in global health, when it's got heated and political, people have dived under the table and, oh no, we can't deal with that. It's political. We need to get out there, and I think particularly for, you know, medical students and students, if you believe in an equitable health system, you've got to fight for it. And you know, all the marches around London for the NHS, this is the thing to do. And to answer your question, Arush, you know, about, I think it's a mixture. I mean, I think the global fora, you know, the high level meetings, you know, sometimes, you know, that it can feel a bit of a sort of beauty pageant, and you know, sort of people not really taking the agenda seriously, and the focus on getting all the wording right on these treaties and everything being a bit over the top. But you need that to some extent to sort of set the pressure and the benchmarks, and you know, that people are talking about it. But as you'll see from the Commission, our focus is on domestic reforms, and that's where the rubber hits the road, and you know, that's where the budgets get decided, that's where the benefit packages get decided. And I do agree with you. I think there's an overemphasis sometimes on the global stuff, ignoring, say, the titanic battles being fought out in the Indian health system at the moment. 1.2 billion people. If India spent 1% of its GDP on its health system extra, $26 billion a year every year, and that dwarfs the 15 billion that's been raised for the Global Fund over 3 years. And yet so much of our attention is on the Global Fund replenishment and not on covering the Indian population.
Okay, we're getting into the last few minutes. Yep. So I know there are a couple of hands on this side of the room. Yours was up, and so I think it might just be these last two. I hope I haven't missed anyone. And I'll see if there's any final comments online. Please.
So my question has partly been answered yet. It was about the role of international organizations and the high-level meeting. My question was, do you expect or hope something from it? And what would be your key recommendations for this forum in September next year?
Right, great question. Expectations for the high-level meeting. Yeah.
Okay, so what are the expectations for the high-level meeting coming up? And
so I imagine that physicians and healthcare workers can be valuable active players in these particular goals. I also can imagine that they run the gamut of being passive in this role, also sometimes maybe counter to the goals. What are some practical things that healthcare workers, physicians in particular, could do within their context to aid this universal health coverage within a political?
Good idea. Yeah. And so yeah, what can health workers do to further the cause of UHC? Maybe I'll deal with that one first, and then I'll talk about the high-level meeting sort of next year. Yeah, multiple ways. I think really, you know, sort of the obviously in providing the services in an equitable way, and sort of always adhering to the policies of allocating services according to need, and you know, it is health workers who are providing the services and you know, sort of doing fantastically there. But I think as well, being prepared to be whistleblowers, to call out bad things, to tell it how it is, You know, you see some very brave health workers in the UK calling out the demise of the NHS at the moment. You know, the long waiting list, the problems with the ambulances, and that can be difficult. You know, that can be hard and to do. Or as well, doctors going into politics. You know, my MP, Rosena Allen Khan, is the MP for Tooting, and she's the shadow mental health minister. She started off as she still is an A&E doctor in St George's Hospital in Tooting. And so she'll do a shift in A&E and come into Parliament and tell it how it is. And, it scares the living daylights out of the health minister. So that's a very smart thing to do, to actually engage in politics. And coming on to the high level meeting, I think what would be good is to see further commitments to the UHC movement, to see heads of state sort of signing up to that. I'd like to see, and in fact, we're discussing this at the moment, some tougher targets about setting public health expenditure and really saying to governments, unless you're spending 2% of GDP, you're not serious, and every country could do that if they wanted to. So creating more peer group pressure for countries to step up. But what would be wonderful, I think, if that could be used as an opportunity to showcase some of the countries that are implementing UHC reforms at the moment. And maybe if one or two countries were to step up and use that to say, we too are going to do this now. That one country I'm watching a lot is Bangladesh. I think Bangladesh has got a great opportunity. And if a big country like Bangladesh were to really go for it, then that would potentially bring health services to 180 million people. And that's the way we're going to get there.
Great. There are one or two comments online. That was a really nice summary, but I don't want to neglect our online audience at all. So the last two comments I see, and this will be the last ones we take. What's the recommendation for LMICs with a high informal sector? And then the next comment is that informal sector is not homogenous. So I'm not sure what's meant by informal sector there. I don't know if you... Yeah,
I mean, basically people not in sort of salaried employment, sort of getting... And it's absolutely crucial, that if you're serious about universal health coverage, everyone should be covered from the outset. And I think we're learning that you need to tax finance, you need to publicly finance, people in the informal sector. That's what Jokowi did when he was governor of Jakarta. You don't means test. You don't say, you're poor, so I'm going to give you a card, and you're slightly not poor, so you don't get a card. It becomes a universal entitlement. That is one of the key lessons, I think. Yeah.
Okay. Right, I think we are out of time, but that's been fantastic. So if we can just give a round of applause to Rob. Thank you so much for joining us and taking so much time to answer questions. Thank you all for coming in a very busy last week of term with possibly conflicting things going on. I know some of our students have, there's a PhD dinner tonight, so some are running to that. Others had conflicts with some of their teaching opportunities. So really appreciate you coming. Thank you for joining us online and making it so successful as well. Rob, wonderful to have you. And real pleasure. Yeah. Thank you.
Thanks.
Carl, I'm just going to end the meeting from here.